Good evening and welcome to Woman. Our topic tonight is depression. Depression has been called the epidemic of the 70s. It is a major public health problem in the United States. My guest this evening is Myrna Weissman, co-author of The Depressed Woman, a study in social relationships. Dr. Weissman is an associate professor in psychiatry at Yale University and the Connecticut Mental Health Center. She has published extensively in scholarly journals and has contributed articles to several books. Welcome to the show, Myrna.
Hi, nice to be here.
Myrna, I have a friend who says that all women are depressed.
Well, it's hard to make a statement about all women, but an awful lot of them are.
Is there widespread evidence that depression is on the increase in the general population?
Well, yes, but that's very complicated because we see more people coming for the treatment of depression. And over the last 10 years, for example, at Yale, there's been a marked increase in that diagnosis. But, you know, there's now better treatments for depression, and people tend to come for treatment for that for which they can get help. And we're also much more aware of depression, and there's more facilities to get treatment now with the mental health centers being available to people from all walks of life. So that people who perhaps wouldn't come for treatment until they got very sick and needed to be hospitalized are now coming.
Has there been an increase among women?
Well, there's always many more women who are depressed than men, and that's true in all countries. There's been an increase in suicide attempts among women, and that's a reflection, although it's sort of indirect, of depression. As an epidemiologist, it's hard to know how much is reporting and how much is real on these things.
How does it fit in? How does depression fit in with our national health priorities? I mean, where is it?
Well, all mental illnesses, except perhaps for alcoholism and drug abuse, which have been singled out, certainly have less funding than diseases, chronic diseases such as cancer and heart disease, which have a high mortality. Depression has what we call a high morbidity. It just ruins your life and makes you miserable. And these disorders now have less funding, which means that there's less research going on in them than might be. Also, national health, the national insurance systems that are being proposed tend to limit the amount of psychiatric coverage, so that people who have depressive disorders, when we do have some kind of and if we do have some sort of a national scheme of health care delivery, will have less of it paid for.
Your book is a study.
Yes.
Why did you do the study, and exactly what did you set out to do?
Well, we saw in our clinic that, and this most people know, that when you're depressed, your life is miserable. And if people around you are miserable, your family suffers, you suffer, you can't take care of your children. If you have children, you don't usually get along with your husband or wife. And we wanted to study this, to see what exactly the impairments were. No one else had looked at that, although there was a lot of clinical folklore. We also wanted to know how long they lasted, and that was the most important question. You know, we can treat depression now with medication and psychotherapy or a variety of treatments, and we can reduce the symptoms of depression rather quickly. And the question was, okay, once you've reduced the symptoms of depression, do all these other accompanying impairments, all these problems in living, do they go away? Or do they last? Are they part of a person's personality?
Give an example.
Well, for example, a typical depressed woman, when she comes in, will complain about getting along badly with her children. Either there's overt friction, they're fighting, or else she can't take care of them. She may even report that she doesn't love them as much, or she doesn't have warm feelings for them, or that she resents their demands. And and there's repercussions. People feel that way, and the children begin acting up. Well, how long does that go on? Once she starts feeling better, does she go back to being the normal self? What is her normal self? That's what we wanted to know.
One of the unusual things, or a little unusual, about your study is that you did use a control group.
Yes, well, you know, if we hadn't used a control group, we would have the book would have been maybe interesting, but still only clinical observation. And we really needed to compare it against something. I mean, what if everyone is having trouble? And how would we know that our depressed people are any different than anybody else? So we did select out a control group. And what we did was to say, what if this person were not depressed? If we selected someone in this woman's neighborhood who was like the woman in every way, same age, relatively same social class, same education, and lived in the same neighborhood, but had never been depressed, wasn't depressed now, never had a psychiatric illness, never went for treatment, what was her social functioning? What would she be like? So we looked at the depressed women, and then we asked the same question of these normal controls. We call them the normal neighbors.
What was the makeup of the group of depressed women? I mean, were they married? Were they single? Did they have children?
Yeah, the typical woman was married, had children. Very few of our patients weren't married. From all social classes. Depression hits all social classes, but they tended to be more from the middle and lower middle classes because there's more people in that social class. And they tended to be in the age 30 to 40, although we had them from 20 to 60. But that was the average person.
Do different people mean different things when they talk about depression? I mean,
oh yeah, it's very much part of our everyday life.
Maybe it would be good if you said,
yeah,
you know, what you mean.
Causes a little confusion. Well, we like to say, to distinguish it three ways. There's a mood, there's a symptom, and there's a syndrome. The mood depression is something all of us have during our life, and we have it frequently. It's Blue Monday, feeling sad, transitory symptoms of feeling, well, life isn't quite up to what you'd like it to be. We call that normal blue mood, and that goes away, and that's certainly not what we treat. That's part of the human experience. Then there's the symptom of depression, and that's feeling blue and sad, and that's a symptom that many people who aren't primarily clinically depressed may have. People who are suffering a physical illness may have some of these symptoms. Other psychiatric patients often have them. But then there's the syndrome of depression, and that's what we study. Now, the syndrome of depression includes feeling sad, feeling blue, looking sad, reporting that life isn't worth living, and having some of what we call the secondary symptoms of depression. And that would be loss of interest, loss of pleasure, loss of appetite, often weight loss, and sleep disturbance.
Hopelessness?
Feelings of hopelessness, helplessness. Life just isn't worth it.
Now, that's not acute depression.
Yes, that would be the acute. Someone who looked sad, who said they were sad, and had those secondary symptoms of depression, we would consider having the syndrome of depression and to be acutely depressed.
All right, so those are some of the ways one can tell if one has a family member or...
Yes.
Another thing that I'm sort of interested in is the correlation between female sex hormones and depression. I mean, isn't that a thing that's said? Premenstrual tension in depression, that kind of thing. Depression along with menopause or even childbirth.
Yeah.
Now, is that true or is that not true that there is a correlation?
It's a hard one to answer in a simple sentence. Let me say, first, let's talk about menopausal depression. I've reviewed the literature extensively with my colleague, Dr. Clareman at Harvard, and there is no evidence that there is either a distinct pattern to the depression that occurs in women who happen to be in the menopausal years, or that there's an increase in depression in the menopausal years. Now, there is absolute good evidence, backed up, well-designed studies, which show that there is neither an increased incidence of depression nor a distinct pattern around the menopausal years. Menopausal depression is a myth. And what happens is if a woman comes in, is depressed, and happens to be in her menopause, she gets a diagnosis of menopausal or depression, or what we call involutional melancholy. I understand that it's going to be taken out of the Diagnostic Statistical Classification Manual as a distinct entity.
And what about the empty nest syndrome that is also very often laid on menopausal women when their children have suddenly left?
Well, certainly there are a number of women and even men who feel sad and lonely. They feel lost when their children leave home. There's also some women who feel, free. They can now devote their time to taking care of themselves. And I've seen in one of the local counseling centers a number of these women coming back and saying, it's now my time. I mean, they miss the children, but it's not entirely a loss. It's also a gain of time.
You describe in the book some social maladjustments of depressive women. Would you talk about that just a little bit?
Well, we found that at the height of the Depression, women were acutely impaired in all their functioning. In other words, their lives were miserable, their lives were wrecked. Their marriages were very unsatisfying, their sexual relations were diminished, they weren't that interested in sex. They continued having sexual relationships because they had also difficulty saying no, but they felt a lot of guilt and resentment and anger. They were having a lot of difficulty taking care of and getting along with their children. And they were not going out socially. They were not getting the sort of pleasures in life that we all get. Now, one thing we did find, though, is that women who worked kept up work and were less impaired in their work than they were in their home life.
Let's talk about housewives for a minute. There's some so-called myths about housewives, too. One is that the more obsessive a person becomes about the tidiness of their home, the more likely they are to be depressed.
Well, that's the benefit of a control group. We found that a lot of our depressed women were very obsessive about their house. The kids couldn't eat cookies because the crumbs would get on the floor, things like that. We also found some of the normals, too. That's why you need a control group. I mean, there are a significant minority of women who are very obsessional about their house.
But it doesn't mean they're going to be depressed, right?
No, it's not something exclusive to depression, not as far as we found.
There were some other myths about housewives, too.
I'm not sure now.
Well, the association of the housework with the family relationships was another.
Well, the women were not able to carry out their housework. They resented, the housework sort of symbolized taking care of a family they weren't getting along with and a family that wasn't meeting their needs. And many of the women just took to bed. As one woman said, "I'm going on strike." This was not true, though, for the women who worked. They kept up. And this was not entirely because they needed the money. There was something about getting out of the house that was protective. Even though they were very depressed and they were under treatment, the work outside the home was distracting. Many of the women went and got jobs in the course of the treatment.
Is it necessarily true, though, if a woman is stuck at home and cannot find a way to get out, that she's going to be depressive?
Well, I think anybody who's stuck in something that they can't get out of is at risk. But for the less educated woman, she's in a bind because, unless the family's going to make accommodations for her, the work she's going to do on the outside may be as physically demanding as the housework.
How does that double burden affect them?
Well, that's not too pleasant. We saw women who go out and get a job because there wasn't enough money in the house for children's clothes, and then find that she was working as sort of a maid on the outside, and then she'd come home and there were all the dishes. And the concept of the working woman in the lower class family is not that clear. And her husband had some feelings about her having her own money, and felt he wasn't going to help. It was, it's hard to talk. You talk about one in individual cases. It's hard to draw generalizations. But in general, if a woman has less education and then tries to get a job on the outside, she's got a double burden.
What about the nature of the impairments on marital and sexual relationships? What is that like?
Well, marriages were characterized by a lot of friction, a lot of fighting. It was either overt physical fighting or it was throwing dishes and resentment and anger and internalized anger towards his spouse.
Did the women who were in the study, did they have poor marriages before the diagnosis? I mean, before any illness?
Well, marital problems was the most common reason that a woman came for treatment. That was the most common reason. That far surpassed any other reason. We asked them systematically before they came, what was the thing going on that was most troublesome. Now, there was a small subgroup of women whose marriages were very good and who had supportive husbands. And even those marriages suffered because sexual relations were diminished and the husbands felt very guilty that maybe they had caused it. Sometimes the women, because they did have a close relationship, they didn't want to confide in the spouse, to upset the spouse, so that they were left without anyone to talk to. But for the most part, marital problems were the major reason women said they were coming for treatment.
Were there problems communicating also?
Oh, that was a major area, was communicating. There was a lot of fighting and arguing and anger, but it was the communication of needs, wishes, and desires that was very impaired.
How do you think this social role conditions a woman toward this? Do you think it plays an enormous part or no part or?
Well, I think it probably does play a part.
That's really kind of the question, isn't it?
Yeah, I think that's not a question we handled in the book because we try to just describe what we saw. So, but I think if you asked me to speculate about it, I'd say that certainly, a woman is not trained to be assertive or to feel that her rights, her needs, her wishes should be directly stated. And that was a problem the women had. It was a problem that we discussed a lot of in therapy. I mean, teaching the women that you say what you want rather than throwing dishes. Not that all women, depressed women, have this problem, but this was certainly one problem of a number of the women.
Did you find a lot of role rejection?
What do you mean?
Women rejecting their roles as wives, mothers, housewives, whatever?
Not really, no. No, it was a very traditionally oriented group. It wasn't, for the most part, an educated group, although there were all social classes represented. I think we're finding that more now. Remember, the study was done in 1968. We're finding more of that, much more now in our population of women.
What about the problems in the interaction between the depressive mother and her child? How do they manifest themselves?
That was very serious because depression puts a mother in a very untenable position. Children they want to be taken care of. They need to be taken care of, especially young children, but even older children, they want someone to set models, to set limits, to talk about what's been going on. Now, a depressed person has no energy. They want to be taken care of, so that a woman who's depressed and who's a mother is being asked to give to her children the very thing that she needs herself, which is attention, support, a chance to be dependent. It's very hard.
What effect does this have on the children?
Well, children start acting out. They get into all sorts of trouble. No, the children got into lots of trouble. Young children, well, they just were active in the house. A lot of things were broken, got into fights. There was a lot of fighting between the children. The older children, the adolescents, they got into a lot of mischief. We saw children whose grades started to go down. Child who started stealing. I mean, things that
But this is generally
really
an interim thing. I mean, it's not something that lasts after the mother is well.
For the most part, it when the mother improved, the children improved.
What about the effects of the children on the mother?
Well, now, of course, there were a few cases where the mother's depression was a result of being in an impossible situation with the children. The children were making demands. For example, a woman whose son was a drug addict. Another whose son was having trouble at that time with the draft. I mean, these were very desperate situations. The parent couldn't find a way out. And it was, you know, in those cases, and also the spouse wasn't very helpful. And in those cases, you know, it was the children's behavior that was perhaps producing the depression in the mother. But usually it was the other way around. It was children began acting up when the mother became depressed. It was very strong
How large a
association.
part does guilt play in depression?
Well, that's a symptom. And that's one of the symptoms of depression. Not all depressed people report guilt, but most of them do. They feel guilty for past things they did, or they feel guilty that they're not performing up to par. Depressed people have high expectations for themselves. And the depression, the way they are when they're depressed, is a radical departure from the way they usually are.
Can you describe maybe just a little bit, you know, give an example?
Well, when we saw these women when they recovered, you know, you wouldn't recognize them. They looked differently. They took care of themselves. They held jobs. They took care of the home. They proud parents. They were solid citizens. There isn't a deterioration between after the illness is over. They go back to functioning. And you know, someone who's getting along pretty well in their daily life and have a depression happen, with all the things, the impairments that accompany depression, they're just not like, they say, well, gee, I'm just not like I used to be.
Is there an age pattern? Did you recognize that? I mean, are women at certain ages more susceptible than others?
Well, it used to be that said that depression was a disease of middle-aged women. We see them all ages now, and we're seeing many more young women in their 20s. Over the last 7 years, the age of our population in the clinic has decreased.
Do you think it's, you know, a product of social functioning or genetic, or, you know, do you have those kind of answers at this point?
Nobody has those answers. Everybody has one part of the answer. But, well, before we answer why, there's one thing we must remember. There are more young people than there ever used to be. Remember the baby boom of the 50s after the war. These people are now entering their 20s, their mid-20s, and that's entering the age when they could become depressed. So there's just more young people, and therefore you see more young people. If you go out in the streets, you also see them more in psychiatric clinics. But I do believe that the rate of depression, the numbers of these young people in proportion to the numbers that exist in the population, has increased too. And I think it probably has to do in part with social isolation, with stress. I mean, there's employment stress, there's people live in a state of uncertainty and transition.
What about treatment, Myrna? I mean, you recommend psychiatric intervention, unquestionably, right?
Yeah.
Well, how do you justify that in terms of some of the criticisms that are being leveled at the psychiatric profession at this point as not really serving women as well as they should be?
Yes, well, there's two kinds of treatment. And, of course, not all treatment for depression has to be with a psychiatrist. Matter of fact, most treatment for depression is not by a psychiatrist, it's by a general family doctor. There's two kinds of treatment. There's usually the psychopharm. Now we're talking about depression, that's serious depression, the syndrome of depression. We're not talking about mild states or transitory feeling lousy and blue. Now, There's psychopharmacologic treatment using antidepressants, and that's, I mean, as long as the doctor knows how to give the medication, that's not sexist. And then there's the psychological treatments. And, well, I think you have to choose your psychiatrist the way you would choose your friends, you know. You should know something about the psychiatrist's attitudes. There are many more women in psychiatry now. Also, the psychological treatment doesn't need to be done by psychiatrists. There's other professionals who are well trained to give sort of psychological support. The important thing is that the person have a confidant, and that the person who's depressed has social supports. And this can be done through psychotherapy with a psychiatrist. It can be done through a variety of other ways. And certainly there's a lot of self-help groups which I think can be very useful.
So you're generally optimistic about the prognosis for depressive then?
Oh, it's very good, yes.
Do you think there are further areas of research that are essential that should be gotten into? We have just a very short amount of time. Is there something important we should be doing that we're not?
Well, we have to know more how these medications work that we're using. I think that's an important area. How do they really work? What is the mechanism? I think we should also know more. I think it's important to try to understand why more women are depressed than men. That's a very important question, and that gets into the genetics, the physiology, and also I think very important the social role and the
Myrna,
stress.
we're out of time.
Okay.
Thank you for being here. Thank you for watching, and good night.